Good evening, everyone. My name is Luigi from Amsterdam University, Mahidol Oxford Research Unit, and also Miulli Regional Hospital in Italy. The aim of today, I have no disclosures, and the aim of today can be summarized in these points. So we will first look at some basic principles of lung ultrasound, and then we will go to image acquisition and interpretation. And in the image interpretation, we will go a little bit deeper into some of the conditions that we will find in our ICU and in our emergency department, like pneumonia, like edema, effusion, and pneumothorax. And after this first introduction lecture, we will have an online survey for you to interpret some lung ultrasound images together with Dr. Nyat. And we will then move on to lung ultrasound in COVID and COVID ARDS. So starting from the basic principles, the indications to lung ultrasound can be summarized in a diagnostic indication for when there is a patient deterioration or an unclear X-ray, or when we want to monitor evolution or response to therapy of our patient. What do we see on lung ultrasound? It's really important to remember that this is different from other techniques. When we put our probe on the skin, we will see some artifacts, which are called A-lines, these horizontal A-lines that you see here. They are artifacts, and they mean that the lung is well aerated. It is very important to remember that the lung ultrasound can only look at the subpleural examination, so this small area, when the lung is well aerated. If the lung is pathological, then we might look deeper. But please remember that when you see A-lines, like here, you're only looking at the subpleural region underneath the pleural line. Thank you. So for example, this point here is not equivalent to this point here because the ultrasounds are reflected back to the machine when the lung is well aerated. We will have different artifacts in different pathological conditions. And it's important to remember that as air decreases, we will have the appearance of other artifacts that we will see briefly. Okay, so let's go to how to acquire the image in our ICU. You can stand usually on the left side of the patient, but some other people prefer to stand also on the right. A very important concept is that lung ultrasound is a tomographic tool. Just like computer tomography, the term tomo means to cut. So we need to learn how to cut our patient in order to get good images and interpret them well. So for example, in the anterior chest, I am here performing a transversal scan, but in the lateral chest, we will put the probe more oblique. One very important error that we do every day is to do the incorrect angle of insonation. So the probe must be perpendicular to the skin, perpendicular to the lung surface. Otherwise, you will get pathological conditions, or they look pathological, but they are not. So please be careful on how you scan during lung ultrasound. And we can use many probes. For example, in children, one probe may cover the whole child, but of course, in adults, you might have to use many cuts to examine the whole patient. And the machine can be old or new, it's a technique that it's based on artifacts, on errors often, so it will work also with older machines. How many zones shall we scan? Which protocol to use? There are many protocols out there, but please do not be worried about protocols too much. In the ICU, we scan, for example, 6 areas per side because we want a systematic evaluation. In the emergency department, where they are more busy, maybe they only scan 3 zones. And the blue protocol is also 3 zones. The more important thing is to remember that air will go up, and so you need to find air on top, while pleural effusion will go with gravity down. And so we need to look for it in the dependent zones. Don't worry also about knobs too much. We only have few knobs to regulate in lung ultrasound. The most important is the gain, the depth, and the frequency. The size of the machines is getting smaller and smaller, and so they are getting simpler and simpler. For example, in a study we are now conducting in severe malaria, we are also using handheld machines, like I think many of you have in your pockets in the hospital. And also on the probe, we can use a linear probe for pneumothorax because it has resolution, a high resolution. But for more obese patients or to look for consolidations, we may use the convex abdominal probe. But in summary, just use the probe that you have in your ICU. It can be linear, it can be convex, it can be sector. Just use the probe that you have. So how do we, what do we see in a normal lung? Maybe many of you already know this, but let's recap very fast. We have A lines and lung sliding, where by lung sliding, we mean this movement of the pleural line due to the respiratory breath of the patient. So A lines and sliding, they characterize the normal lung on ultrasound. But please remember, as we said before, every ultrasound beam gets reflected back to the lung ultrasound probe, just like with a mirror. And because the beams are reflected, they will create reverberation artifacts, which are called A lines. When we go on the lateral chest, we will see the lung sliding as a curtain sign over the liver. When the mirror breaks, when there is superficial pathology in the lung, we will see different artifacts in the lung. So any pathology, it can be fluid or cells, will create the mirror to break and a different artifact to appear. This is the vertical artifact called B line. If the density increases even more and the air is obliterated completely, then we get a pulmonary consolidation. Very good. It's important to remember that these patterns, they are in continuity between them. So it depends on the amount of air in our lung, in our alveoli. So you can imagine that we can pass from a B pattern with B lines to an A if, for example, we give a diuretic like furosemide. Please also remember that B lines, they are vertical artifacts, as we said here. They can be separated or they can be confluent. And we will look today at what is the difference between separated B lines and confluent B lines. And in the survey after, you will be invited to classify images between separated B lines or confluent B lines or consolidation. it is very important to remember that a B-line will always appear when there is an increase in density. Density is the keyword. If density increases, B-lines will appear. This is a very important concept. It's not only interstitial fluid and pulmonary edema that causes B-line to appear. Any increase in mass, so the formula of density is mass divided by air. So any increase in mass, any increase in mass or any decrease in air will create B-lines to appear. So for example, in pulmonary edema, it is fluid. But when we have pneumonia, it is cells, it is mass that increases, they will create B-line. Or when we have a decrease in air, simple decrease in air, like postoperative atelectasis, for example, also we will have B-lines. So lung ultrasound is also a densitometer. It estimates density. Sorry if I took a few minutes to explain this, but it's a very, very important concept. I come from Italy, and in Italy, we like to cook a lot of food. And I like to compare the lung ultrasound findings like ingredients in our kitchen. So we have A lines, separated B lines, confluent B lines, consolidation, effusion. They are like ingredients. And in Italy, we love these 5 ingredients very much, for example. But the aim of today is to interpret how do I go from findings, from ingredients, to build my diagnosis. And I really like this article from the Toronto group that really nicely explains how to go from lung ultrasound findings to lung ultrasound diagnosis. And also in your meetings in the morning, you don't want to speak of findings, A line, B line, consolidation. You want to tell your colleagues, how is the patient going? What is the diagnosis? What is the evolution? And this framework called indication, acquisition, interpretation, medical decision making may help you or to go from findings to diagnosis. We do not have time to look all in detail, but I hope that today's lecture will help you to make this process. And we can also use the simple lung ultrasound score. So A lines, separated B lines, confluent B lines, consolidation. You can imagine that we can use this simple classification to build some common diagnosis. For example, if you find a consolidation monolaterally only on one side of the lung, it may be a pneumonia. But if you find the same consolidation, but bilaterally with a dishomogeneous pattern with B lines everywhere, this may be ARDS. Let's look in detail now in some syndromes or some diagnoses. So, interstitial syndrome. Let's remember a B line, it's a vertical artifact that arises from the pleural line and goes until the end of the screen. Sorry now. And we have a positive field for interstitial syndrome when you have more than 2 B lines in the single field. And we have diffuse interstitial syndrome when we have at least 2 fields per side. And for example, pulmonary edema will be classified when you have bilateral, symmetric, diffuse B lines with often confluent B lines. For example, in this image, you have so many B lines that they are confluenced together and they appear like a white lung. There is a lot of literature into the sensitivity of lung ultrasound for the diagnosis of pulmonary edema and extravascular lung water. And you can use B lines to follow the patient. For example, this was a child with severe malaria. So for example, he arrived with A lines, then some B lines developed, B lines, then a pleural effusion developed, and then at discharge, the A lines came back. Consolidations, they are hypoechoic, so black images, which have an irregular border in their depth. So why do we have B lines under the consolidation? Now you can understand. Remember why B lines develop, because there is an increased density. So this is the consolidation, okay, but these are B lines because the tissue near the consolidation is also an inflamed tissue. This is a lobar consolidation, and this is smaller subpleural consolidation. It is important to know the bronchograms. These are the presence of air inside the bronchi. You can have straight bronchograms more in atelectasis, or you can have a tree-like bronchograms in inflammatory processes. Here we see a lobar consolidation with dynamic bronchograms inside and a little bit of parapneumonic fluid. And you can see the bronchograms, they are dynamic because they move and they become like a tree structure with inspiration. So now let's see another diagnosis. There is a patient coming to the emergency department with hypoxemia and these two patterns. So you ask yourself, is it A, B, C, or E pattern? But the important question will be, are they monolateral or bilateral findings? Are they focal or are they diffuse? Is it homogeneous, like in pulmonary edema, or is it dishomogeneous, like in ARDS? And my message to you is that you can already imagine what the CT scan will be. Look here in the front, you have normal A-line pattern because you have normal fields, while on the back, you have some ground glass on the CT, and you can see the B lines appearing on the lung ultrasound. So this is an example of non-hydrostatic pulmonary edema because it's dishomogeneous, bilateral, dishomogeneous patterns. And in the COVID lesson, we will see how does COVID ARDS present. In the last 5 minutes, let's look at pleural effusion. I think many of you use lung ultrasound to decide on the quality and quantity of pleural effusion. In this case, we have a small phlogistic pleural effusion because there is a pneumonia, a lobar consolidation. In this other case, we have a large pleural effusion due to heart failure. And then you can also speak about the quality. For example, here you have a pleural effusion next to a tumor, a lung tumor. In this other case here, it's it's a loculated, a septated pleural effusion with the septa inside that you can see. There are many ways to estimate pleural effusion. We do not have time, so only one method, BALIC, for example, you multiply the interpleural distance by 20 to obtain an estimated quantity of pleural effusion. And to finish with pneumothorax, what you find in pneumothorax is A lines, but without sliding. There is no sliding in pneumothorax. So if you see sliding, like in this case, if you see sliding, you can be 100% sure, 100% specificity that there is no pneumothorax. We will skip the lung point for today because time is over, and we go to the final part, medical decision making. Always integrate lung ultrasound with the clinical context and with the assessment of the heart, of echocardiography. The lung ultrasound is a very, very sensitive technique, but it lacks specificity. So our work is to increase the specificity of lung ultrasound. Thank you very much.